Thank you very much, Stamatis. So we carry on. We are very good in time with Dr. Ntoskas, who will refer to CMR in cardiac hypertrophy, differential diagnosis. Dr. Ntoskas is a consultant cardiologist in Limassol, Cyprus.
I think it's a pre-recorded talk, isn't it?
Oh, thank you. Thank you. Thank you,
I think
Stamatis.
so, yes.
Morning. I am honored for one more year to be invited and participate in the Athens CMR level 1 to 2, and I want to thank Dr. Mavrogianni. I am very sorry for this video. I have because of a change at my flight schedule. Today we're going to talk about the CMR in cardiac hypertrophy. Cardiovascular magnetic resonance has been established as a valuable tool in clinical and scientific cardiology. In this study, we can see the current evidence and role of CMR in the guidelines of the European Society of Cardiology. As you can see, CMR is an integral part of the majority of the ESC guidelines. Its representation in the guidelines has increased since the last analysis from 2015, now comprising 92 instead of formerly 63 specific recommendations. For this reason, to enable patient management in accordance to the ASC guidelines, CMR must become more widely available. 2023 guidelines for cardiomyopathies upgrade the CMR role as protagonist in distinguishing of the phenotype of the cardiomyopathies. The main reason of this, of course, is the unique ability of the CMR to characterize tissue. Apparently, it's doing so excellent job to that at the most recent guidelines for myocarditis in 2025, CMR findings are equal to biopsy. The role of CMR in hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is defined by the presence of increased left ventricular wall thickness that is not solely explained by abnormal loading conditions, such as hypertension or valvular disease. In an adult, hypertrophic cardiomyopathy is defined by a wall thickness more or equal to 15 millimeters in one or more LV myocardial segments as measured by any imaging technique, echocardiography, cardiac, MRI, or CT, that is not explained solely by loading conditions. The clinical diagnosis of hypertrophic cardiomyopathy in first-degree relatives of patients with an unequivocal disease, LVH with more or equal 50 millimeters, is based on the presence of otherwise unexplained increased LV wall thickness more or equal 13 millimeters in one or more LV myocardial segments. Common genetic cardiomyopathy presents in 1 in 500 individuals in the general population and caused by mutation in genes encoding proteins of the cardiac sarcomere. Hypertrophic cardiomyopathy is characterized by a wide range of clinical expression ranging from asymptomatic mutation carriers to sudden cardiac death as the first manifestation of the disease. The diagnosis, as we talk, is based on the presence of a maximal LV wall thickness, although enormous diversity is present in the pattern, location, and extent of wall thickness, as you can see. Here we have sigmoid septum and some asymmetric septal hypertrophic cardiomyopathy, mid-cavity, apical hypertrophic cardiomyopathy, and concentric. And we're going to talk about that later. Here we have a focal septal hypertrophy with obvious turbulence in the LVOT area due to systolic anterior motion of the mitral valve leaflet. CMR is excellent for the visualization of the sum, however, is limited in reliable measuring dynamic outflow tract pressure gradient and in particularly provocable gradients. In this slide, we have a common asymmetric septal hypertrophic cardiomyopathy. Here we have another variety of hypertrophic cardiomyopathy with thickening of the mid-apical LV walls. CMR is superior to echo for apical hypertrophic cardiomyopathy. CMR demonstrates loss of apical tapering with apical hypertrophy in diastole and systolic apical cavity obliteration. Here we have very nice images of a concentric hypertrophic cardiomyopathy. So what? Similar images we can have with echocardiography. Why we need to do a CMR? And with echocardiography, we can have accurate determination of pressure gradients generated from outflow tract obstruction at rest and dynamic. But CMR imaging has the distinct advantage by virtue of producing images with sharp contrast between the blood pool and myocardium to provide highly accurate LV wall thickness measurements, robust quantification of LV and RV chamber size, LV mass, systolic function, and can identify areas of LVH not well visualized by echo. CMR imaging has also expanded our appreciation for the diversity in morphologic abnormalities, including LV apical aneurysm, as well as structural abnormalities of the mitral valve and subvalvular apparatus that contribute to LVOT obstruction, findings which may impact management strategies. Apparently, CMR can clarify clinical hypertrophic cardiomyopathy diagnosis when LV wall thickness measurements remain ambiguous by echocardiography, as well as provide a precise assessment of wall thickness measurement. Indeed, in some situations, LV wall thickness measurements can be underestimated by echocardiography compared to CMR, particularly when hypertrophy is confined to the anterolateral wall, apex, and posterior septum, which are regions of the LV wall in which focal areas of increased wall thickness can be echo silent. And this paper identified this discrepancy. Let's go back to our focal septal hypertrophy with SAM and go step further with the post-gadolinium imaging. And in this case, we can see that there's no any late gadolinium enhancement. This was our asymmetric septal hypertrophic cardiomyopathy, and in this case, we can see diffuse, extensive late gadolinium enhancement, which is definitely more than 15% of the total LV mass. Here is the case with the mid-cavity hypertrophic cardiomyopathy, and in this case as well, we can see patchy mid-wall late gadolinium enhancement, which is very typical for hypertrophic cardiomyopathy. In our apical hypertrophic cardiomyopathy, there's no LG. Overall, approximately 60 to 80% of the cases of hypertrophic cardiomyopathy, LGE is present. Before go forward, it's very important to mention that the post-gadolinium enhancement images post-gadolinium imaging, the black part is good and the bright is bad. So the bright area can be fibrosis, scar, infarct, infiltration, but definitely is abnormal. Let's discuss about the prognostic role of the CMR and in particular the LGE. Initial studies demonstrated a strong relationship between the presence of LGE and an increased risk for ventricular tachyarrhythmias on ambulatory monitoring, suggesting that LGE may represent an novel imaging marker of future risk for life-threatening arrhythmias. So, just early research showed that assessment of LGE can be used as an effective tool for risk stratifying patients with hypertrophic cardiomyopathy. The presence of late gadolinium enhancement by cardiac MRI predicted all-cause mortality, cardiac death, sudden cardiac death, aborted sudden cardiac death, and heart failure death. More recent studies demonstrated that the presence of LGE is associated with an increased risk for sudden death events. In this one, by Chan, including more than 1,300 hypertrophic cardiomyopathy patients followed for an average of 3 years after CMR, extensive LGE occupying more than 15% of LV mass was associated with a twofold greater risk for sudden death compared with patients with no LGE. Additionally, the absence of LGE was associated with a low risk of adverse events and a measure of reassurance. Just to mention, RV insertion point is a common area for LGE to be seen in hypertrophic cardiomyopathy, but it's not a reliable predictor of adverse hypertrophic cardiomyopathy related events, including sudden death. These results pushed Americans to release updated guidelines for hypertrophic cardiomyopathy and sudden cardiac death. In these recommendations, we can see the role of CMR in 3 out of 7 points. In particularly, it reports that non-sustained VT has greater weight when associated with another risk marker, particularly LGE. It recognizes the connection between diffuse and extensive LGE and sudden cardiac death, and finally adds the left ventricular apical aneurysm identified by echocardiography or CMR as another risk factor for sudden cardiac death. All the cardiologists were very familiar with this hypertrophic cardiomyopathy risk for sudden cardiac death calculator since the guidelines released in 2014. Of course, we use that for many years. However, according to this slide, the ESC model is associated with higher specificity for identifying patients unlikely to have events, potentially decreasing implants in low-risk patients. However, sensitivity of the ESC score for identifying individual patients at risk for sudden cardiac death events was only 34%. So only 1/3 of our patients implanted based on individual ACC/AHA markers and with appropriate device therapy terminating ventricular tachyarrhythmias would have received high ESC risk scores, more than 6% over 5 years, sufficient to justify primary prevention ICDs. The remaining patients would have been left unprotected from sudden cardiac death without ICDs. Additionally, you can see that LV apical aneurysm, extensive LGE, as well as systolic dysfunction were associated with more than 25% of appropriate ICD therapies in this study. Although notably, none of these markers are part of the ESC risk score formula. So, without surprises, the updated guidelines in 2020 by the American Cardiology Society increased the power of the CMR, both on diagnostic and prognostic terms. With indication 1, patients suspected to have hypertrophic cardiomyopathy in whom echocardiography is inconclusive, CMR imaging is indicated for diagnostic classification. Additionally, for patients with the left ventricular hypertrophy in whom there is a suspicion of alternative diagnosis, including infiltrative or storage disease, as well as athlete's heart, CMR findings is useful. We discussed previously about the increased role of CMR in prognostic terms, and in particularly with the use of the extensive and diffuse LG. Undoubtedly, the role of CMR in hypertrophic cardiomyopathy recognized as well in Europe, and now has strong indication 1B for diagnostic workup in all patients with hypertrophic cardiomyopathy. That makes sense because the natural history and management differs according to the underlying etiology of LV hypertrophy. Diagnostic workup is of paramount importance and includes CMR and genetic test. This paper emphasizes the prognostic role of the progression of late gadolinium enhancement in hypertrophic cardiomyopathy. So CMR should be repeated every 2 years in patients with hypertrophic cardiomyopathy because the extent of late gadolinium enhancement may increase rapidly in a relevant percentage of patients. Additionally, the high rate of progression of LGE, defined as the increase of LGE extent more than 0.07 gram per month between 2 consecutive CMR examinations, is the best independent predictor of major arrhythmic events. The role of CMR in differential diagnosis of left ventricular hypertrophy is unique. Here we have a nice case of amyloidosis with extensive subendocardial late gadolinium enhancement of the left ventricle and the left atrial as well. And here we can see the very pathognomic high ECV, extracellular volume. It is very important for early diagnosis of cardiac amyloidosis, as currently we have targeted treatments with excellent results. Diagnosis of sarcoidosis is very challenging, and for this reason, we cannot be definite sure without finally a biopsy. At the CMR, sarcoidosis can mimic other conditions like myocarditis. However, it gives us very good information. As you can see here, we have extracardiac findings like hilar and mediastinal left nodes, and we have at the same time extensive late gadolinium enhancement with edema at the T2 stir images. And this means that we have an active inflammation. Here we have a very nice case of an RV Shepherd's crook, which is pathognomic imaging finding at the CMR for cardiac sarcoidosis. Here we have a typical CMR presentation of a patient with Fabry disease. We have concentric left ventricular hypertrophy. On post-contract image, 4-chamber and short axis views, area of late gadolinium enhancement is found in the mid-wall layer of the inferior lateral wall, which is the typical site of LGE in Fabry disease. at T1 mapping, a diffuse decrease of native myocardial T1 is found. Finally, take-home messages. CMR can give us excellent anatomical assessment in patients with hypertrophic cardiomyopathy. Gives us precise wall thickness measurement, and it's the gold standard, especially when wall thickness is borderline or apical hypertrophic cardiomyopathy is suspected. It's excellent in detection of focal or segmental hypertrophy, not well visualized on echocardiography. It's a unique tool for tissue characterization and indicates replacement fibrosis, presents in up to 60 to 80% of hypertrophic cardiomyopathy patients. It's well established nowadays that the extent of LGE correlates with risk of sudden cardiac death. Additional advantages: sequences with T1 mapping and ECV gives us extra information, detects diffuse interstitial fibrosis even in areas without LGE, and helps in early disease detection and monitoring. Regarding the apical hypertrophy cardiomyopathy, CMR is superior to echo in visualizing the apex, where hypertrophy may be missed on an echocardiographic scan. We can differentiate hypertrophic cardiomyopathy from mimics, as we discussed, and is the gold standard to assess the LV function and the LV mass. Thank you very much.
Thank you, Dr. Ntoskas. This presentation was recorded, and we have two questions that we might discuss with each other, and also involving Dr. Mavrogianni, Professor Mavrogianni, Sophie. So the first question is, isolated 16 to 17 millimeters of interventricular septum on echo or CMR. Is it diagnostic for HCM, for hypertrophic cardiomyopathy? Sophie, what is your opinion about this?
First of all, it's not obligatory to find the same values by CMR. Maybe it's more than 17 millimeters or even less. So it's not, values are not interchangeable between the two modalities. Also, the ejection fraction is not exactly the same between echo and CMR. So we have to verify the hypertrophy. Second, we have to compare the intraventricular section thickness and the lateral wall and see the ratio of these two. And how is generally the hypertrophy of the left ventricle, and also other concurrent factors from the history of the patient, from his or her activities, and of course the presence of gadolinium, which is very important, and also the values of T1 mapping and ECV. So we don't decide about the diagnosis using only one parameter.
I agree with Sophia. If
we are clinicians, not imagers. We are clinicians, and this is the big
exactly.
Cardiologist.
It's not pathognomonic. It's very likely, isn't it, Sophia Michalis? But it is not pathognomonic. We have seen hypertensive patients with this sort of thickness. We have seen athletes with this sort of thickness, or Fabry disease or amyloid with this sort of thickness. But so it's not pathognomonic, it's quite likely. So we have to consider some other clinical and laboratory factors as well.
And the other thing I like to emphasize is that CMR gives us the potential to evaluate the term of hypertrophy. In the past, we describe everything as hypertrophy. Now we can characterize the hypertrophy. Hypertrophy may also be a transient finding, as in myocarditis. So we don't know what it is if we don't analyze the patient after a very careful, I emphasize this, medical history, which we always ignore, and we are used to have just a tool in our arms and say, I apply my modality, I apply my technique. It's not, this is not true. We have, first of all, take a very careful history and perform a very careful clinical examination of the patient. And after that, we have to ask the help of the modalities.
Okay, we have a second very interesting question alluding to mabamacamtane treatment, which is known to reduce the LVOT gradient. This was actually not referred to in the presentation, so the question is very well taken. Do we have any changes in the myocardium, for example, LGE-T1 mapping, ECB-T2 mapping, under mabamacamtane treatment in hypertrophic obstructive cardiomyopathy? Do we have any data on this?
I don't know details about this, but I know that even in HOCAM, you can find areas of very high T2 mapping, which means that there is a sort of inflammation due to the hypertrophy. And this could happen also in hypertensive heart disease, and even more common in kidney heart disease, which is characterized by hypertrophy, and also in hypertrophic cardiomyopathy. So anything that compresses the muscles could provoke edema. Even after therapy with a sort of ablation, alcoholic ablation, we can identify areas of edema in the septum, in the area of the ablation. So there are many factors that can contribute to the increase of T2 mapping in hypertrophy generally, and more specifically in HOCAM.
Stamatis, would you like to add something to this?
Yes, I would like to stress an important point, and actually I would like to ask Sophia as well for this. Dr. Ntoskas stressed a very important point of repeat CMR. Every 2 or 3 years, I don't know how often, because progressive fibrosis occurs more frequently, especially in young and to middle-aged HOCM patients. And so the percentage of LGE with respect to LV mass might be deteriorating over time. And the other thing is that 15% in HOCM adults might be no, the other way. Less than 15% is also a high risk factor, especially in younger HOCM patients. What do you think, Sophia?
Look, there are many issues on this. First of all, the quantification of LG. There is no international agreement on how to quantify LG. Usually, it is common that we do it using 5 standard deviation according to Maron studies, and this is what we apply. Second, indeed, when we have LG, it means that we've lost myocardium, except in case LG is due to myocarditis, where we can expect an improvement in LG or even disappearance of LG. It is, in this case, it's only in myocarditis, so we expect this. Otherwise, in cardiomyopathy such as HOCAM, we expect stability or even increase of LG. And the LG is definitely an area of fibrosis that may provoke arrhythmia, and depending on the size of LG, we can expect even worse arrhythmias. I definitely agree with the guidelines that we have to perform. We prefer to perform a CMR every year, or not every 2 years in young people, in order to see if there is an evolution, but using always the same machine and the same way of quantification, which is important, because if you change the standard deviation, you get a different number. So it's important to apply same protocol, same machine, and the ideal is same doctor who will validate the patient. But definitely we have to perform serial follow-up in these cases. And the other thing we didn't say is that we can see extensive myocardial infarction with normal coronaries in these patients. And maybe these patients not die because of the LG due to HOCAM, but due to the LG of the coronary artery disease with normal coronaries. Just keep it in mind as an option.
That's right. On the other hand, Sophia and Michalis absence of LGE does not preclude the risk of adverse events in HOCUM.
No, but it's
Yes.
not as high as.
It's not that high, yes.
However, a death is an electrical phenomenon. And even in athletes without LGE, we found a sudden death just because
That's
this is an electrical phenomenon, maybe due to, let's say, for Parkinson-White or ventricular tachycardia for whatever reason, emotional or anything else. It's the same thing we have in Takotsubo, which is not always LG, which mainly is not LG, but they may die suddenly.
And atrial LG, we forget.
It's very tricky.
Remodeling, yes.
It was in the past supported by Marus that they can find it. We are not very happy with the results of these measurements, except in case of the interatrial septum, where it's more clear and easier to detect LG, and we see it very often in patients with systemic sclerosis. If LG is in the wall of the atrium, it's really difficult to detect and quantify. However, maybe new softwares and also artificial intelligence will give a better solution in all these issues. I believe that imaging will be greatly influenced by artificial intelligence. And it will open new ways, even in patients who cannot give contrast agent, we can represent, using the T1 values, the potential of LG without contrast. So this is great innovation, and many people work very hard in this field.
Okay. Shall we proceed? Yes, Michael?
We have a final question by Dr. Maragianis, who will be the speaker of the next presentation. And I think that he has alluded this comment to the mavacamten treatment in HOCUM. He informs us that there are some small cohorts that they have seen LV mass reduction, LA volume reduction under mavacamten treatment, but big data are still to be elucidated and to be awaited. So we lent over, we're still very good in time, to Dr. Maragianis, who will have a lecture on CMR in heart failure with